Welcome to another episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and I'll be hosting this episode. I've been looking forward to this all day. I have a wonderful guest with me, and I have a fairly complicated, unusual case, something that we don't see very often. And it'll be interesting to pick her brain, see how she approaches these types of patients. And I look forward to learning from her. She's someone who I learn from every time she speaks. She is an outstanding neuromuscular specialist and EMGer, and this should be a great episode to pick her brain and learn about another neuromuscular disease. So sit back and relax and enjoy this episode. Well, welcome everyone to the next episode of Lessons from the Lab. My name's Devin Rubin. I'm a neurologist at Mayo Clinic in Jacksonville, Florida, and it's a great pleasure to have a wonderful guest with me today, a very special guest, Rubin and Narayanaswami, who's an associate professor of neurology at Harvard Medical Center. She's vice chair of clinical operations for neurology and an expert neuromuscular specialist in EMGer. And it's great to see you, Pushpa.
Hey, Devin, it's really good to be here with you. Thanks for inviting me.
Oh, I know. We've been trying to connect for this for it seems like a year to find time, and I think you're much busier than I am, but I'm glad you were able to take a little chunk of time out of your day.
Well, I think we're just busy on different days, so our days never meet and match, so we found today, so I'm happy.
I think it would have been a first for this if we would have recorded like we were saying at an AANEM meeting recently. We were just going to go during lunch, I think, or dinner and just record this, but that wouldn't have been fun. So
okay.
So, well, how are things up in Boston?
Pretty good. I mean, today for the first time, we've got temperatures up in the high 70s after a very long time. Yesterday was cloudy and rainy, so I'll take it.
Okay, so you're getting to be at the weather that we have like 3 months ago. It's hitting you now.
Yeah, okay, brag already.
But it's already 100 here, so I think I'd rather be up there. So anyway, I appreciate you taking the time. As I think this is an educational series put out by AANEM, and really the goal of this is for us to chat with each other. And I'm going to present a case that we've seen in our EMG lab recently, and just kind of pick your brain and talk about how you would approach this patient. I'll show you a couple images of what we did, but kind of talk through do we have similarities or differences and how we would approach a patient with a neuromuscular problem. So sound okay?
All right, I'm taking a test now. It's like exciting, right?
Actually, I just spent the last 5 hours reviewing test questions for an ABPN examination on a committee. So I've been reviewing hundreds of questions, so I'm primed and ready to ask you some questions.
Let's go for it.
All right. Well, I'm going to start off, I'm going to share my screen, and hopefully this will work.
Perfect.
And some people who listen to this are on podcasts, so I'm going to just I'm going to read this out loud for those who are not watching this on YouTube, so they see or can hear what we're seeing. So this is the patient that came to us a couple months ago, and it was a 68-year-old man who had a history of bladder cancer that was treated with intravesicular chemotherapy, but otherwise he was healthy, and he came to us because of progressive weakness. And basically his history started years ago when he was in high school, where he was athletic. He didn't have any problems keeping up with the other kids in sports. However, he noted that when he would lift weights, he had difficulty building up his pecs. He couldn't be muscular like me. Not really. So but he tried to do weights. He couldn't build up his pecs, but otherwise he didn't have any problems. And then it wasn't until about the age in his 40s, about age 45, where he started noticing some weakness in his arms. And he said when he would hammer a nail above his head, using either arm. He had a harder time hitting the nail and holding his arm up. It just seemed more effortful, not because of pain, just because of weakness. And that persisted and gradually worsened. And over the next 10 years, when he was in his mid 50s, he started noticing that he was stumbling when he would walk on uneven surfaces. And he said that was because his feet were weak, and he started noticing foot drop bilaterally. And it was pretty symmetric. And then again, gradually over time, he noted some atrophy more in the proximal arms and as well as his legs. He had some slight muscle discomfort, but pain really wasn't a big issue. And that was mainly his symptoms. He had no bulbar complaints. He had no problem swallowing, no diplopia or ptosis. He denied experiencing any sensory symptoms in his extremities, and really no other symptoms. And he didn't have any family history. He had a sister, he had two daughters, they were fine, nothing with his parents. And he had been evaluated before coming here a little bit, and he was noted to have a slightly elevated CK of about 400. And that's what we had. So what do you think? What goes through your mind when you've probably seen lots of patients like this?
Yeah, pretty cool. So this guy is 68. Now, one of the reasons you trick me, I think you want to trick me, is by giving me like this past medical history right there in the first line, right? So I'll anchor and have this anchoring bias to history of bladder cancer, and he's received intravesical chemotherapy. I actually teach the residents that probably the old-fashioned way to present past medical history later after the present history is probably a better way to do that. Although I think we've all sort of gone to this, somebody with hypertension, diabetes, stroke, in the first line. So if I thought about it, immediately my mind is jumping to, oh, wow, he's got bladder cancer. He's had intravesicular chemotherapy. Could all of this be some complication of whatever is happening? I haven't even read the second line. Then I read the second line, and you're giving me some clues there. In high school, he played sports without difficulty, which tells me that his legs were strong. Maybe his arms were strong if he was playing basketball or volleyball and throwing, or, tells me that. But he couldn't build up his chest muscles. Well, some folks can't build up their chest muscles. I don't know how much to make of it, but I do I'll keep that in the back of my mind when I'm looking at the rest of it. And then I'm looking by age 45. Now here there's a problem. And, all of this, I assume, is sort of developing gradually. Nothing is sudden. He sort of is gradually noticing it. Is that fair, Devin, to say sort of this is a gradual progress? So you're talking to me, you're giving me a history of somebody who's having these gradually progressive issues with basically weakness. So difficulty hammering a nail above his head suggests to me that the proximal muscles of his upper extremities are weak. And then you tell me that it's bilateral, so it's symmetric. So he has symmetric proximal muscle weakness, or at least fairly symmetric. There could still be mild asymmetry when we examine it. It doesn't have to be as severe on both sides, but it's reasonably symmetric. And then by 54, he starts stumbling when he's walking. And here we're talking a distal weakness. So the pattern is sort of interesting here. And I guess we can get to that in a minute. But he's got proximal upper extremity weakness bilaterally, fairly symmetrically, maybe. Then he's got distal weakness in his lower extremities. So if he's stumbling when he's walking, you start wondering whether he's not clearing his toes, when he's walking. And so he's sort of tripping. And then clearly you're telling me that there's slowly progressive bilateral foot drop, and that's what's making him stumble. And then he's got some atrophy. Okay, now I don't know the muscle groups that are involved here, but I do know that there's proximal upper extremity and distal lower extremity weakness. I don't know whether he's got other weakness in the arms and legs, like distal arms and proximal legs in this little sort of presentation. And he doesn't seem to have any bulbar symptoms, but I'm not sure whether he has any facial weakness or not. I don't have information here to tell me. I know he doesn't have swallowing trouble, so the bulbar, I know he doesn't seem to have ophthalmoplegia, but I don't know whether he has facial weakness or not. So I don't know that bit of information yet. And he doesn't have sensory symptoms. So what is this telling me? He's got a gradually progressive, fairly early onset if I take into account the buildup of the chest muscles, or at least in middle age, onset of progressive weakness that's involving the proximal upper extremities and the distal lower extremities, with some degree of atrophy that comes on later, without a family history and with a mild increase in his CK. So overall, I'm thinking here, okay, so I have, so in my mind, when I look at these, the first thing I try and do is to localize it, right? We all do that in neurology. So where is it in the neuraxis? I've decided that because you're giving me this case, it's a peripheral case. Just kidding. You know,
Yeah.
the history.
I wouldn't give you MS. Don't worry.
Well, I'm just kidding. The history, though. I mean, the whole overall history suggests that this is outside the central nervous system. It's only weakness. There's no sensory involvement. So it's either a neurogenic process, which is purely motor, or it's a myopathic process. That's the way I would look at it. And then, the CK is mildly elevated. It's not like leading me very strongly neither way. You can have mild elevations of CK with even neurogenic processes like motor neuron disease or SMA. So that mild elevation is not giving me a whole lot of information. There's no neuromuscular, but I'm not getting a sense of the rest of the family, whether mom has something or mom's brothers have something. Maybe mom doesn't have anything, because it's interesting. He has only one sister and two daughters, so no male relatives. So it's sort of hard for me to decide, if there could be some family history that I'm not getting here.
Yeah.
What do you think? How would you have
Yeah,
approached it?
no, I think that's a great synopsis of just the history that you have. And one question I was going to ask, getting back to your point, important point of the CK. So I think what you said is in neurogenic disorders, you can have an elevated CK. Is there a number that sort of I know not an exact cutoff, but a number
Yeah,
that would make you think, I'm really more concerned about a myopathy based on the CK. And obviously we take everything into consideration, but
absolutely.
if it was 2000, would you say that's probably not neurogenic?
Absolutely. I
Yeah.
mean, if it was, I remember seeing a paper. You're right, there isn't any absolute cutoff. And I think it's sort of nice to sort of place that in some perspective. I remember seeing a paper a while ago. This was when, we started looking at hypercikaemia and the genetics, just as, genetic testing came out. And this was in neurology. I don't remember where it came from, but the number that was sort of cut off for, if they don't have anything else on exam, they just have high CK and you're wondering whether it's a myopathy and you want to go into a muscle biopsy, 700 was the cutoff that I had.
Mhm.
So, and I think that's a reasonable cutoff, actually. It's sort of about 3 times the upper limit of CK in most labs, like 200, 180, 200. So it gets you to about 700. I sort of think that's a good one for me.
Yeah.
If it's anything below 700, I'm not too excited about it. It doesn't mean I don't pay attention to it, but I sort of watch it. I watch for other data.
Yeah. And I guess to that point that we certainly see myopathies where the CK isn't elevated. There are certain
Absolutely.
diseases. So that the lack of elevation of the CK doesn't exclude a myopathic process.
Very good point. Because I mean, you have the definition even in acquired disorders, amyopathic myositis, where you don't actually have a raised CK.
Yeah. Yeah, exactly. So, okay. So what would you do next? How would you, and to the family history, as far as we could tell through the history, his parents didn't have any signs or symptoms of a neuromuscular disorder. So
Okay.
there really wasn't any other family history that we could elicit of anything
Okay.
similar.
What's his ethnicity, Devin?
He's Caucasian, and I can't remember where he's originally from.
Okay.
Probably somewhere around Jacksonville, but I
Okay.
don't know where his family's from.
Right. Okay. That's good.
So what next? What would
Exam, please.
Okay. Yeah, exams are important, aren't they, in neuromuscular
Hmm.
disease? Okay.
Yeah,
So,
because you build, right? I mean, I've got this story now. I'm going to build another layer based on what you tell me.
Yeah, yeah, exactly. So here's and remember this is at Mayo
Oh,
Clinic. So our motor gradings, not MRC, it's 0 being normal, -4 being 100% weak, right? So
okay,
this,
0, -1, -2, -3, and -4, like
yeah,
25,
so
50, 75, and
exactly,
100. Got
exactly.
it.
So 0 is good, -4 is really bad. So I'll just summarize
He's
this.
got facial weakness.
Yeah,
Cool.
so he has some mild facial, and this is for the people listening. He has some mild symmetric facial weakness in the forehead, the orbicularis oculi, and oris. And in his upper extremities, he has quite severe weakness in his pectoralis and elbow flexion and extension mostly. So biceps and triceps, with a little bit in brachioradialis and wrist extensors, and not much distally, just a couple muscles
Got
minus.
mild weakness of both finger extension and flexion.
Yeah, yeah. And well, not flex. This was taken from a colleague, but so flexion wasn't graded, but thumb abduction was -1.
Oh, sorry. Yeah.
Yeah. And then in the
So we've
leg,
got, I'm sorry, I'm just going to
okay. Yeah,
look at that again. So we've got deltoid weaker than the
yeah.
pectoralis. So I
Deltoid,
think,
deltoid normal.
oh,
Deltoid,
0,
yeah.
sorry, never mind. Yeah,
Yeah.
sorry.
So
So,
deltoid is normal, and biceps and triceps are severely weak, 75% weak, and
oh,
pectoral.
okay. And they are weaker than the pectoralis. Okay, that's perfect. Okay.
Yep. And then in the leg, he had kind of diffuse weakness that was mild proximally from his hip flexion, and quads and hamstring, but very severe distally and ankle dorsiflexion. He really couldn't dorsiflex at all on the left and trace movement on the right. And then he had some weakness in plantar flexion as well. So distal more than proximal leg weakness.
And but sort of really no selectivity, it looks like almost all muscles are about the same,
Yeah,
affected to the same degree. There appears to be mild asymmetry, but not a lot, but it's not perfectly symmetric.
yeah,
Is that fair to
correct.
say?
Yes, yes.
Okay.
And then his reflexes were absent, -4 in the upper and lower extremities. And he did, despite um, not having any sensory complaints, my colleague picked up some sensory loss to all modalities distally in his toes, in his feet.
Just mild distal
It's
sensory
mild,
impairment.
yeah. So mild, and I don't want to get, be too confusing, but that was pretty mild. And remember, he didn't complain of any sensory symptoms.
Exactly. And his neck flexion and extension are normal.
That was normal. Yep.
Okay.
So
Atrophy, patterns of atrophy. Do we have anything?
there was, yeah, I didn't put it down, but it was noted that there was significant atrophy in the biceps and triceps and pectoralis. And then I believe that there was atrophy in the anterior tibialis muscles as well.
Okay. All right. All right. So this is interesting. He has the addition. What do I have additionally from the history? I have confirmation that he does have indeed some facial weakness, upper and lower facial weakness, mild, but it's there. He does have, so the proximal girdle, the infraspinatus, supraspinatus are normal. But he does have, and it's really quite striking, the degree of weakness that the pectoralis, I'm sorry, the biceps and biceps is like 0, right? 75% weak
Yep.
or 50% weak, -2.
Yeah, -2 and -3 on the right. So there was a
No,
little,
-3. So it's 50 to,
yeah,
yeah.
yeah,
So the biceps is much weaker. The deltoid is paired, but the pectoralis is slightly weaker. Between the biceps and the triceps, there isn't much difference, right? So that's the selectivity we have. And in the lower extremity, distally, much weaker than proximally, again with mild asymmetry, but no selectivity, it looks like. It looks like both the plantar flexors and the dorsiflexors are involved. Now, I think couple of things that would be interesting to know here is what the EDB looked like. And I always teach this, that with this degree of weakness, if there was EDB atrophy, if the extensor digitorum brevis was flat, there wasn't a muscle there, then that would sort of lead you one way compared to if the extensor digitorum brevis was the nice fat extensor digitorum brevis there, right? So in most myopathic, in most distal myopathies, the teaching usually is distal weakness is neurogenic, proximal weakness is myopathic. Now here we've got both, right? So you've got to confuse me. So you're giving me somebody with both of these. So okay, fine. So I'll deal with it. So here, if I looked at the extents, and now we know over the years that there are this group of disorders that can be called that are called distal myopathies, where the weakness is distal predominant. We also know that eventually many of the myopathies end up involving the distal muscles too. But here it's not an eventual. It's not like the end stage disease that he's got. He's got better preserved muscles proximally. So that's not the issue. So how do I decide? Say this guy didn't have upper extremity weakness, the proximal, which tells me that this is likely to be myopathic. He's got some face weakness. That's telling me it's likely to be myopathic. But if I didn't have all of that, if you just told me he had bilateral foot drops and this was the picture, if I saw big EDBs, I would say that's a myopathic foot drop. If I saw atrophic EDBs, I would say that's a neurogenic foot drop. So I think that's sort of what I was trying to get at here in a very long-winded fashion. I'm sorry.
Is that because myopathy, even distal myopathies, don't affect the very distal foot muscles, but affect more, anterior and posterior compartment, whereas as we know, neuropathies really start as distal as possible. Is that the rationale that sparing?
Exactly.
Yeah.
Yeah, I think that's one of the rationales. The other rationales is that in a myopathic disorder, weakness is out of proportion to the degree of atrophy. In a neurogenic disorder, atrophy is out of proportion to the degree of weakness because they lose the trophic effect of the neurons, the motor neurons, Right. So for both those reasons, yeah.
Yeah. And then back to the face. So, most people who read a basic textbook about myopathy, it's proximal muscle weakness, and the face often isn't affected, but there are myopathies that the face can be affected, right?
Absolutely.
So are there certain things that, in your mental list of if it's myopathy and it's involved in the face, do you have a list of things that you start thinking about?
Yeah, as we learn more about these disorders, I'm just going to say one other thing to sort of expand. We didn't talk about the pathophysiology. We talked about the anatomic localization. Just a minute, because I think we're ready to sort of look at the pathophysiology here, if you're okay with that.
Yeah.
So because of this very long, very slowly progressive history, I tend to think that this is a hereditary disorder, an inherited disorder, or genetic disorder, let's put it that way. I have very little other differential diagnosis because it started very early. One of the differential diagnoses for a very slowly progressive but not genetic disorder is inclusion body myositis. But this clinical picture is extremely unusual for acquired inclusion body myositis, not hereditary inclusion body myopathy, but acquired inclusion body myositis, where the classic pattern is finger, FPL, finger flexor, which he's got here, but a lot of quadriceps atrophy and quadriceps weakness. So you're not seeing that. So I really don't have much of a differential diagnosis. I think this is a myopathy, notwithstanding that mild sensory involvement you're seeing, because you can see that in some myopathies too. And I don't know how much to, sort of worry about that. So I think this is a hereditary myopathy. So then now you're telling me he's got some facial weakness. So I sort of start thinking about things. There's also some mild asymmetry of weakness. There's not a lot, but there's mild asymmetry. And there's this proximal upper extremity and distal lower extremity pattern, right? So when we look at myopathies in the days before genetics, we had to have sort of tried to fit these myopathies into specific boxes. We used to say limb girdle pattern, where you have proximal upper extremity, proximal lower extremity weakness. That's very typically myopathic, but this patient clearly doesn't have a limb girdle pattern. Then we used to say facioscapulohumeral pattern. And I don't have enough information about the scapular muscles here, but this could certainly be FSHD. Now, but then you're telling me, I'm sure, are you going to ask me a question, Pushpa, but he's got leg weakness. What about that? Right? Distal leg weakness.
Right.
So facioscapulohumeral dystrophy often is actually facioscapulohumeroperoneal dystrophy. It involves the distal lower extremity muscles. But there's also a scapuloperoneal dystrophy, which is different from the facioscapulohumeral dystrophy, where you have proximal upper and distal lower extremity weakness. It's different. So that's the other one I'm thinking of. I'm not really thinking too much of the limb-girdle muscular dystrophy syndromes, but we now know that there are patterns where, for instance, dysferlinopathy, you can have proximal and distal weakness. The patterns go together. Dysferlinopathy and octominopathy. The patterns go together as the disease advances. And in some families, you can have some people having distal, some people having proximal. The face is unusual for that. And the CK is very unusual for that. Dysferlinopathies and octominopathies have very high CK. A little bit unusual for that. But as we learn more and more about these dystrophies, one thing we need to keep in mind is how much phenotypic heterogeneity we have and genotypic heterogeneity we have. So if you have the same genotype, dysferlin, it can present with multiple phenotypes. So I keep my mind open. But that is sort of, I'm going to give you as the initial differential diagnosis for this, if that makes sense.
Yeah, no, absolutely. That's a great sort of thought process. I guess the other thing, I guess, to throw in there or exclude, but can involve facial muscles is myotonic dystrophy. And
Yes.
that can have distal involvement.
Yeah.
But I think it's a little unusual distribution here in this patient.
I thought of it. The only reason I didn't bring it up because the third nerve is normal. There's no ophthalmoplegia. There's no mention of ptosis. But sure, proximal myotonic myopathy or DM2, myotonic dystrophy type 2, but that tends to be more proximal as the name indicates. So it's not fitting in neatly for me into that myotonic dystrophy group. But you're right. I did think about it. The reason I didn't say it was the cranial nerves.
And the other one, and I'm not asking you this because it's like a board, this isn't like the boards, but it's for people listening. Are there any neurogenic disorders
Yeah.
that can cause slowly progressive facial weakness
Yep.
in a man and have
Yep.
distal weakness?
Totally.
Yeah.
Yeah.
So,
Kennedy syndrome is what you're
yeah.
talking about. They can have a lot of facial weakness, very slowly progressive, doesn't start quite this early. It usually starts a little bit later. And the pattern of weakness is otherwise very reminiscent of a motor neuron disease, so it can be proximal and distal. So absolutely, we look for gynecomastia. The other thing that's that is very common in them is a mild neuropathy, so that sensory stuff can fit in. So that is a really good differential for this one, I think.
Yeah.
I mean,
okay.
in terms of the phenotype.
Of all that, right, exactly. So no, that's
But
fantastic.
one of the things is that of everything, I still say common things commonly first, right? And rare things rarely. So I would still think facioscapulohumeral dystrophy. There was a paper from the Mayo Clinic, actually, Lyle Jones, I think, several years ago, just when we got the genetic testing for FSHD, that went back and looked at a whole bunch of patients from the Mayo Clinic records and looked at the phenotype and sort of showed us this phenotype that could be so variable. In some people, facial weakness developed very late on in the illness or not at all. And I have a patient like that. So
yeah. And I think to that point, we presented, not this patient, but it was we presented at one of our EMG conferences a few months ago, and it was a colleague presented a patient with FSH dystrophy that presented with axial weakness, not the typical. So I think you're right that condition can have so many different presentations. Sometimes, we've seen patients just with scapular winging and kind of subtle and maybe just a little bit of atrophy of a pectoralis, but no other weakness in the limbs.
exactly.
And they had that. So yeah, very heterogeneous. So
Yeah. It would be nice to know some extra exam details here, like the high riding border of the scapula, whether there are inverted pectoral folds. It would be nice to know that, but we don't know that.
yeah, and I don't think this has been a while. I don't think, if I recall, that I can't remember yesterday, but I don't think he had any prominent scapular abnormality. So
Okay.
at least that wasn't as obvious as the weakness that it was shown here.
Okay.
So if you're seeing this patient, then what do you do, an EMG, or do you go just to genetic testing, or how would you approach this?
Yeah, yeah, very interesting question, right? So I'm sure you want to do an EMG because we've got to talk about EMG.
I do an EMG on anything, so yeah.
But
but but it's no. I mean, it's a
so,
valid question. Could you just do a
but
genetic test
it's
and
a
see?
very fair question. So basically, what you're asking me is, am I sure that this is a myopathic disorder and not a neurogenic disorder? Because that's what I'm going to look for in an EMG if I did an EMG on this person. You know, so I'm not going to look for carpal tunnel, even if he's got one. So that's the whole point. So, and I think in this case, now I do sort of go straight to genetic testing if the phenotype is classic. If I'm looking at this person and saying the probability that this person has FSHD or myotonic dystrophy, and those are the two where it's really simple, and sometimes Becker can be pretty simple. If you have a family history and, if the clinical picture, if I have those, I'll just go straight to genetic testing. In fact, I'll do single gene testing in those, not panels,
Mhm.
but not in this person. I think in this person, I would agree with you and say, let's look at it a little bit and then decide how we are going to approach it.
Yeah. So if you were doing an EMG, how extensive would it be in someone like this?
Right.
Could you
So I'm
just pick
going to,
one muscle when you're done?
So I'm going to look at for a couple of things again, right? So first of all, I look at least at one sensory and one motor nerve to make sure that the nerve is okay, especially since he's got some mild abnormalities. So I probably do a peroneal and a sural and an ulnar motor and sensory. Okay, just look at those nerves. And do you have the data, or do you want me to continue to
Yeah, no,
discuss,
no, no.
or
I'll show you. And well, okay, yeah, I'll show you what we did with the conduction studies.
I can tell you, okay, or I can tell you what else I want, or however you
Oh,
want to do it.
okay. So if you did that, and the conduction study showed mildly low motor amplitudes with normal sensor responses, and that's all you had, no dispersion or anything unusual. And
Right.
then
And where were these amplitudes low? Which nerves?
well, let me show you. I'll just
Okay.
go ahead and show you why not. So actually it wasn't, this is the fibular motor. And again, for people listening, they can't see, um, the amplitudes were normal on the fibular motor. The velocity was slightly slow for
Slightly,
our
38.
values, 38. And then, um, oops. And then this is the tibial amplitude at the knee for our normal value is over 4. It was 3. So slightly low, again, with a slightly slowed velocity of 39. That's slightly slow for us. And then the Searle actually for his age was normal in amplitude, but again, slightly slow conduction velocity of 34. And then we
And
did
its temperatures are normal,
the
so I'm happy
temperatures
with
are
that.
normal. Yeah. It was technically, yeah, good point. We will make sure that none of this is technical. And then we actually did a little bit more extensive conduction studies because of this, went up to the
Because of
R.
this, yes, I
Yeah.
would too.
Yeah. And then it gets, these are real life cases. It's not like a perfect, everything's perfect and what maybe not
Yeah.
necessarily one thing, but here the median motor distal latency was a little bit prolonged with a slowed velocity.
And now you're wondering if he's got a carpal or if
Yeah,
this
I
is
know.
part of the whole
So we're
process.
not going to go down that route in this discussion, but maybe, yeah, right. And then I'm going to just skip the F waves. The F waves are normal. His
Yeah.
ulnar motor conduction velocity was a little bit slowed.
Yeah, even, yeah, 45, 50 is our upper limit of normal, I mean, low limit of normal. What is yours?
Ours is 51. So
51.
basically the
Okay.
same. Yeah. And
And
then,
the amplitudes are normal.
yeah. So
Yeah, just
green,
a tiny little bit. And this is across the elbow, actually, not in, forearm segment is a little slow too. Okay.
yeah. Yep. And then we did a couple, I'm going to just show a couple sensories in the arm. So the ulnar sensory antidromic. a little bit prolonged latency of 3.1 and velocity was 46. So slightly slowed. And then the
The
median.
plot thickens.
Yeah, but yeah, okay. So I guess the question's going to be the conduction velocities are diffusely a little bit slow. Whether or not it's related or not, or there's two problems. I don't know how, like in your mind, knowing this, I think that's all the conductions we did. What do you think? You think this is now?
Yeah, I agree. I mean, I don't know. The answer is I actually don't know whether there's two processes because the clinical picture is very strongly still myopathic.
Mhm.
So could he have a mild neuropathy that is part of that myopathic process? Because we know that some hereditary myopathies are associated, myotillin, etc., can be associated with an underlying mild neuropathy. So is that part of it? Or is it something non-specific? So I'm not sort of, I'm not sort of really too impressed by this. It's mild, it's subtle, so I'll wait, I think the money's in the needle EMG.
And we know patients are allowed to have more than one condition.
Yeah,
So I always say we write the textbook, but they don't read the textbook, and
right.
so they can have several things. So that's real life.
Yeah. Oh, that's true. I like the We Write the Textbook. I haven't read that one before.
Yeah. So anyway, okay. So the key, I think, you were saying is the needle exam, and I'm just going to show you a
Yeah.
couple clips from a couple muscles, and then I'll show you the summary. But this is from the vastus medialis at rest. I don't know if you can hear, but there were just a few little fibrillations
I
there,
see that. Yeah.
not real prominent. And this is the motor unit activity.
And
So
what's your sensitivity there? I'm trying to
this is
see.
at
And
200 microvolts
okay.
per division. This is the triggered sweep on the right. So
Okay.
10 milliseconds per division on the left, 5 on the right here. So I'll play this again because I think this is an interesting clip, but so I don't know if this comes across is what's happening here on this motor unit, but
There's a second component that comes and goes.
yeah, so it's blocking there. So there's some
Yeah,
instability.
exactly. There's a second component that, you can see that it just comes, and sometimes other times it doesn't. It doesn't show up very much on this week, but it shows up really nicely there. Can you play it
Yeah,
one more time?
yeah,
Oh, you see it here. Yeah.
right here. Yeah. So it's kind of coming in and out and blocking.
Yeah.
So can you have jitter and blocking in myopathies, or should we just be thinking about neuromuscular junction disorder now?
Well, he has too much fixed weakness, I think, to be thinking purely neuromuscular junction disorder. But then now we open up a whole new set of differential diagnosis. So first of all, I think if you want to try to explain it away with the myopathy, when you have a fairly early myopathy and there's a lot of rapid necrosis of muscle fibers. So we're talking a dystrophic process or an active myopathic process, lots of necrosis, there's some regeneration. And you could argue that the neuromuscular junctions there are still not very well formed. They are immature, and you can have jitter just for the same reason, or jitter and blocking just for the same reason that you do in motor neuron disease. So any process where you have destruction and regeneration, and the regeneration is sort of, still sort of not complete, the units are not nicely organized, you can still get it. So, and there were some fibrillations. But then you could ask me, well, he's got some fibrillations, does he now have SMA? The whole picture is not like SMA.
Yeah.
Even with
And
the absent reflexes, the whole picture is not like SMA, the clinical picture. There's too much weakness, not enough wasting. It's just, and the pattern is not like SMA. Even adult onset type 4 SMA doesn't have this pattern of weakness. So I don't think so. So what else can be? He could have two things. We know that there are dystrophies that, have congenital myasthenic syndromes associated with them. So Doc 7, you can have myopathy and you can have a congenital myasthenic syndrome actually associated in the same patient. So am I thinking about that? Not yet, because there's too much fixed weakness. I don't get a sense, like you get this gestalt, when you see this. I haven't seen this guy, but you've given me such a great story. I don't get that gestalt of varying weakness. He's running, he's athletic. I don't get it. So I still think it's a single process. I'd like to see a few more units, like to
Yeah.
see whether,
Yeah.
with
Because I'm
increased
just showing you
recruitment.
one motor unit. So
Yeah, what did you think of
yeah.
this? Do you have anything else in terms of how you would approach this?
I have the benefit of having seen many more motor unit potentials.
Okay, never
But
mind
but
then.
I think the point that, and we see this in other myopathies, if this ends up being a myopathy, that we often think, well, you shouldn't have a lot of instability in motor unit potentials with myopathy, and that can help separate out early neurogenic reinnervation. But we know that single fiber EMG is abnormal in myopathy. So you, just
Yeah.
like you said, you can have remodeling and instability of the motor units. That doesn't exclude a myopathic process.
Yeah, and I think that also brings up the teaching that, before you jump into a single fiber EMG or a repetitive nerve stimulation because you suspect a neuromuscular junction disorder, go ahead and look at the nerves and muscles and exclude anything else going on with them. That's
Yeah,
the whole point, right?
yeah,
It's
exactly.
a question of specificity, not sensitivity there.
Exactly. Yeah. So here's another clip of the vastus. A little more activation. And remember, he's in his mid 60s. So, that I don't know what you think, at least of this. This is a limited clip, and I'll show you another muscle in a second. But I didn't think they were too bad. The motor.
No, and some of them look actually a little bit small.
Yeah.
I don't know,
Here.
you
Yeah.
know, there. I don't know the degree of recruitment. Not much, obviously, So maybe we've got, but that one fills this screen, so it's like 2 millivolts,
Yeah.
and the duration is not really. I mean, it's like 15. I don't know. It's mildly prolonged, but I think it looks okay.
Yeah. 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 But right. To me, I thought it doesn't look floridly myopathic, and
No,
it doesn't look floridly neurogenic. So it was
I
kind of
agree. Yeah.
mildly. But so I'm going to show you the biceps, which
I'm
was
sorry. Which one was this? Was
that
vastus
was
medialis?
that was the best medialis. And remember, he was only
He wasn't
mildly
very
weak.
weak. Yeah,
Yeah.
he
Whereas the
wasn't very weak.
biceps, he was
Very
severely.
weak.
And this is the biceps. He had a few fibrillation potentials in the biceps, and this is him at minimal activation, so barely contracting. So really just trying to start to contract there.
Yeah, wow. So that's that typical early recruitment, right? You see a lot, and you hear the pitch, you hear the tone. It changes completely from what we saw in the vastus. You hear it and you see it, these very brief potentials. Some of them are small, but not all of them are small. Some of them are normal. So there's a mixed bag, and you can see that in a very chronic myopathy.
Yeah.
That's very common. So this, to me, is more consistent with the chronic myopathy. There's some mild polyphasia. We saw some coming and going. None of the polyphasics look very brief. Just these individual units look, the biphasic units look brief.
And I think you hit on something that, I've the sound, and for years I've tried to put a term to it, because you know how we say
Yeah,
that, myotonic discharges sound like a dive bomber or whatever you want to
yeah,
use. And I think, and probably you have the same experience, when you see a myopathy, there's this myopathic sound to
yes,
that segment of recording that it's hard to describe it in words, but
yeah.
it sounds that myopathy or
You
myopathic.
just know it. Yeah.
You just know it. Yeah.
Yeah,
So
but I mean the difference between the two screens. I mean, you don't have to actually see the screen. If you're doing something and somebody is doing this, there's a myopathic EMG there.
right, right. And here's one more clip. This is the triceps, same thing at minimal activation. Then he relaxes, then minimal activation.
Wow. Yeah.
So same kind of thing. I think that's an even better example. And
Yeah, yeah, smaller. Yeah, it's beautiful.
yeah, and
More
if it's
polyphasic.
and I would say in this muscle and the biceps, if he's so weak, mine, 75% weak, if it's neurogenic, there should be markedly reduced recruitment and big.
Yeah, and huge units because it's chronic, and you would probably see like one unit firing, one huge unit firing.
Exactly. Yeah. So you're pretty convinced it's a myopathy?
I'm convinced. So I'm also convinced that it's a myopathy with denervating features, or a myopathy, an irritable myopathy,
Yeah.
which sort of says that there's an active process going on there of muscle destruction. Now, what does that mean in the context of somebody with a what, like 20-year history of weakness? It still means, could this be polymyositis? Because that's what you'd see, right? But again, still in the context of that, you can see that in active dystrophies. You can see that denervation. So I still think I would still sort of be stubborn and stick to my original diagnosis that this is an inherited myopathy.
Yeah. And I think the other point I would add is, although you didn't think this was myotonic dystrophy, there were no myotonic discharges.
Yeah,
So
and that's interesting, because when you were asking me, how many muscles would you do, just one muscle, two muscles, I was going to say, what am I looking for here? I certainly want to look at the weak muscles and the normal muscles, and a relatively normal muscle, to look at the difference. That's really important. And I want to look for myotonia, because if that's one of the values of doing an EMG in a myopathy, you pick up myotonia. And
right,
it can be quite difficult to pick up myotonia in DM2 especially. So you got to be careful.
right. And I would add to that point of myotonia to keep in mind that very brief, rare intermittent myotonic discharges can be seen in some of these other conditions, like
Yes.
isolated. So I think we're looking for diffuse, profuse myotonia to guide us. But if there was a little myotonic discharge, it wouldn't help us a whole lot.
Yeah, and I tend to stick the paraspinal muscles in myopathies to see if there's anything going on there. So, and a good point about the myotonia there. You're right. I mean, you can just see that discharge. The other thing is, sometimes you can see complex repetitive discharges, because these are very chronic, so it's important to be sort of attuned to complex repetitive discharges versus myotonia there.
Yeah, yeah. So this is the table. It might be hard to see, but these were the muscles that were
Yeah, I'm
examined.
sitting
Here,
forward and
the
trying to look.
the paraspinals weren't examined, but there were some distal and proximal leg and arm muscles, and a few muscles had some minimal fibrillations, 1+. Distally, he couldn't activate in the anterior
Hmm.
tibialis or gastric, and there was decreased insertion activity. And then the motor units, were patchy, but they were all short duration and some polyphagia there.
It's interesting. If the process, if you had decreased insertion activity and no activation in the distal muscles, I actually suspect that the process started in the legs, and he
Mhm.
probably didn't notice it. He noticed it when it hit his, and you see that a lot in patients with, foot drop from early onset weakness, Charcot-Marie-Tooth disease, for instance. They walk with this high steppage gait, but they won't even know that they're walking like that. I mean, that's what they do. In fact, if you prescribe braces to them, they don't like it, because it's heavy and it makes them walk different, because they're so attuned to walking like that. Interesting. Really
Yeah.
cool case.
Yeah. And then, so one other question, would you do any imaging of the muscles? Do you do that,
Yeah,
ultrasound or MRIs, or does that
yeah,
not add much here?
yeah. Well, I will say that, there's more and more data about, sort of biomarkers, both diagnostic and sort of prognostic biomarkers, imaging biomarkers in muscle. And in my institution, at least, the rheumatologists always tend to order an MRI. I tend not to order for these. I'm more inclined to order in patients in whom I have an acquired myopathy, to maybe select a muscle for biopsy, help me select if I'm not too sure, etc. I probably would not, although there are some really elegant descriptions of some specific, mostly it's non-specific. Sometimes the pattern gives you an idea, but I guess it's my practice. I don't tend to order in these. How about you?
Yeah, same with you. I mean, I might look more out of interest with ultrasound because we have them on the machines.
Yeah.
And, I think looking at distribution of involvement, although if it's mild muscle involvement, I don't think
Yeah,
ultrasound is very sensitive, at least the ones we have.
yeah,
So I do it more out of interest. But
yeah, yeah.
so
You're right, because that's again becoming an easy to use biomarker than is an MRI. Yeah. So
yes.
I guess we know he's got a myopathy now. It's not a myotonic myopathy, and we've sort of confirmed the distribution
So
as well.
now you want your muscle biopsy or you want your genetic testing?
No, I'd go for FSHD testing on this guy first.
Well, that's what he had and it was positive.
Yeah,
So just like you thought from the very beginning.
that
So
was my first diagnosis.
yeah.
That's
So
a very cool case, though.
yeah, and going back to kind of the EMG report for a second,
Yeah,
just to finally to kind of wrap this up, when you do your EMG report, if you have all this data, in your interpretation, how far do you go in your EMG interpretation? Do you say there's a myopathy? Would you say this is consistent with FSH dystrophy, but not
yeah.
specific? What do you do?
So, good question. I think the answer is it depends. It depends on how confident I am after the exam. It also depends on whether the patient is mine or referred from somebody else. Because you don't want to send out a definitive diagnosis to somebody who may not really know what that means. And then the patient's panicking, and then you can't work them in for like 2 weeks. So I'm a little careful there. So it's nuanced. If this were my patient, I would say a chronic generalized chronic myopathy with mild denervating features in conjunction with the clinical history. This suggests a muscular dystrophy, and amongst others, facioscapulohumeral dystrophy is a consideration. I would say that.
You want to know what I said?
Yeah, I want to know what you said.
So this was my interpretation. Evidence of a chronic patchy but diffuse myopathy. Patterns of findings are not specific, but would be consistent with a clinical diagnosis of
There
FSH
you go.
dystrophy. So similar to you. And I feel exactly the same way. It depends. I don't always say that. It depends on my
Yeah,
level of confidence. And sometimes in my report, I'll say these are not specific, but these would be several conditions to consider. And
I will do
uh,
that too. I'll
like
give a differential diagnosis. Yeah.
yeah, we used to years ago we used to say the pattern is consistent with a myopathy in which there's muscle necrosis or vacuolar changes or
Yeah,
splitting,
I don't say, yeah.
and people don't understand that. So we've
Yeah.
switched to more clinically based interpretation. So and then I
Yeah.
thought his neuropathy, as you said, was probably incidental, not related,
Yeah.
and yeah, so
Yeah. Yeah. I
yeah,
forgot about that. Thanks for
yeah,
putting
he
it
still
in
has
there.
that, but I think that's an important point. I'll stop sharing here. I think it's an important point because, like we said, we like to fit everything perfectly. And as I was saying, I was doing these exam questions, and we like the examination questions to be perfect, but real life's not perfect. And
Yes,
we
it
get
is
these
not.
messy findings, and we have abnormalities that we like to explain, but it's sometimes hard to perfectly explain everything into one condition. So
Oh, absolutely. Yeah, that was such a great case. And you did such a good workup, boy.
well, it doesn't always end that way. And as you know, sometimes the genetic testing's negative and it's
Oh,
something
yeah.
else. And
And then
but
if he had FSHD2 or something, then this would be negative.
right.
And then there's the small proportion who don't have either FSHD1 or 2. And then you're going to sort of do, whole exome sequencing now to make sure it's not something else. And then you'll get like 5 variants of uncertain significance.
Right. And then you're back to square one, right? Saying,
There
well,
you go.
yeah, I'm not sure. So, but no,
Yeah.
I think there's so many teaching points and you hit on so much even from the beginning and just thinking through the process and localizing and the pattern of abnormalities and I agree, the EMG is helpful, it's important, but as a part of the entire
Yeah.
picture. And we should go into the EMG with having an idea of what we think it is and try to confirm.
That is so important, right? Yeah.
That. So, but
Yeah, it is, it's an extension of a clinical exam, right? I mean, really?
Right, right. So, but I really appreciate you taking the time. I know it's coming up on the hour, and it's great to discuss this. I wish we could do this every week, but we might have to wait for another year till we can find a mutually convenient time.
Well, this was really great. I mean, honestly, thank you for pushing and shoving until I found a time. I mean, I truly enjoyed it. This was so fun.
Well, great. Well, it's great seeing you. I hope your week is well, and I hope it stays warm and you have a beautiful summer.
You too. Take care, Devin.
I hope you enjoyed this episode of Lessons from the Lab. That was certainly terrific. Dr. Narayanaswami is an outstanding neuromuscular specialist, and just to listen to her talk through a complicated patient with FSH dystrophy, with a myopathy, really had so many important teaching points for all of us, whether you're in training, whether you're out in practice, and have been doing this for many years. And I think it's great to just hear the thought process, hear uh, how one might separate out or think about neurogenic from myopathic disorders. And when you encounter someone with a suspected myopathy, how the pattern of abnormalities can help narrow the differential diagnosis and make you think about certain conditions. So that was wonderful to hear her thought process, and also to discuss the role of EMG and role of genetics and how they complement each other. And in some cases, the perhaps genetic testing is more important and can maybe go directly to genetic testing and not spend as much time on EMG. I'm always an EMGer by heart. I do think that there's a role, as Pushpa mentioned, for EMG, particularly to make sure that it's a myopathic disorder or distinguish it from a neurogenic disorder. So you'll never get a needle out of my hand. But hopefully you enjoyed it. Hopefully you learned something from this, and I look forward to our next episode. Bye bye.